I am Dr. Randy Cohn,
And I'm Yanira Dawson.
and we're here today to talk to you about care of the socioeconomically disadvantaged athlete and give an overview of social determinants of health and how that relates to patients under our care. So socioeconomic status is the standing or class of an individual, patient, or a group. It can be measured as a combination of education, income, and occupation. When we look at this thing amongst our patients, we can see vast inequities in terms of access to resources and issues related to privilege, power, and control in terms of obtaining necessary health care. Low income and education have been shown to have strong impact on mental health problems, as well as physical problems and orthopedic issues, such as arthritis. We'll talk more about how this relates to a patient example under our care.
Yeah, so as we take a deeper look at the socioeconomic status and how these factors play into healthcare, we see that the conditions in which people live, play, and work influence their health and outcomes, and this is what's known as social determinants of health. These cause major health inequalities and disparities in the U.S. Also, it can be variable based on the access and resources distributed. This can be very problematic because many times the head of the household can be seen as the father, but in some cases, this may not be possible in some households. So what are these determinants and what do they affect? One's education, community, their economic stability, the physical environment, and food inequities all play a role in the effects of the outcomes, such as one's health status, the expenditure for their health care, and their functional status. Looking at this image, you can see that about 20% of a person's health and well-being is just related to the access and the quality of healthcare, while the whole 80% is equal to the outcomes associated with physical environment and social determinants in their behavior.
So we're going to take you through a case report that can be a patient that any of us see on any given day. So we have a 16-year-old male high school football player who sustains a twisting injury to his knee while at practice. He hears a pop and limps to the sideline. He comes over to the sideline and sees one of our traders like Yanira on the sideline. And Yanira, what are some thoughts you have when this person comes onto the sideline?
Yeah, so everything about this case so far appears to be status quo. You know, you want to make sure that you're doing your lower extremity assessment, ruling out a fracture, doing laxity tests, check for effusion and point tenderness. You're obviously going to remove this player from practice, ask these questions, have they hurt the knee before? Any numbness, pain in the knee? What does it feel like? Is it loose? Do they feel like it's giving out? Any stiffness, tightness? And then, you're asking if their parents can come pick them up because you potentially want them to be evaluated further.
So let's delve a little bit deeper into this case. So this 16-year-old student is bilingual with Spanish-speaking parents. The father works in construction. The mother is a caretaker at home. Based off the exam, based off the sideline assessment, there's some concern about a possible ACL tear. So what are the next steps? Do we send this athlete to the emergency room to try to be evaluated? Can we get them to see an orthopedist? Delving deeper, what's their insurance status? Are we going to be able to get them in to see somebody expeditiously? Is there infrastructure in place where the school has affiliations to be able to get this athlete seen soon, regardless of these inequities in insurance? What should the student do now between this injury and the appointment? How is this going to be communicated to the student? How is it going to be communicated to the parents, especially given that he's only 16 years old? So we're lucky here in the sense that this student goes to a school that has an athletic trainer. That athletic trainer and the school is affiliated with the health system, and he's able to see an orthopedist the next day. So we give that student some crutches, instructions to ice the knee. The patient and the family are given the information on when to see the doctor. And the big question comes is, do they understand the importance of this? Do the parents understand the importance of this? Do they understand the importance of seeing the doctor and what this might mean for their kid? And what concerns do we have? Do the parents understand? Is the student who's only 16 going to be responsible for communicating this information to his Spanish-speaking parents? Delving deeper is, how is this kid going to even get to the doctor tomorrow? The father works in construction. He's not salaried. He's on a wage scale. Can he take the day off? Do they have a car to even get him there? Are they relying on public transportation? Assuming they can even get to the doctor's office, what's the insurance status? Is there a copay? Can the family afford that copay? And these are issues that are always there behind the scenes when taking care of our athletes.
Yeah. So all of those questions definitely take into consideration the athlete and his family's social determinants of health. The big question here has to do with the potential language barrier. And while it's not a new topic in healthcare, it's one that's now at the forefront to provide equitable care to all patients. So language is one of the factors that really influence care. And an article in 2008 found that some of the greatest health disparities occur among racial and ethnic minority groups from different cultural backgrounds, and especially ones that do not speak English as a first language. It's also been demonstrated that the Hispanic adults have the lowest average health literacy scores among all of the racial and ethnic groups, with about 74% of Spanish-speaking patients having less than adequate health literacy and compared to English-speaking counterparts. So what are some of the reasons why you may have a low health literacy? It can be because low educational skills, those cultural differences that we speak of, and that limited English proficiency. Your health literacy is the degree in which individuals are able to understand, obtain the basic health information that you give to your patients. It's not really common in, more populations where you have people with higher educations, but you'll see this more in older adults, the minority groups, those who have lower socioeconomic status, and those who are medically underserved. So we have to remember that one's health literacy is important with written and verbal communication. More than half the population may not be able to understand the information that you're giving them about their healthcare status. This puts them at risk of negative health outcomes. So a patient with low literacy will more likely have more visits to the emergency room, those longer hospital stays, have higher mortality rates, and not really follow the treatment plans that you give them. So one of the greatest predictors of a patient's health status is making sure they have higher and improved literacy skills. You can do this by helping them to understand their information, promote patient-centered care, help them to enhance their outcomes by understand and give them that common language that we speak on the everyday and not give them those medical terms. So for your patient safety, you need to make sure that they understand their current condition and the risks, why they must comply with the healthcare instructions that you gave them, and how they can play a role in their own healthcare. You cannot assume one's health literacy status based on looking at them, so it's best to use those patient-centered universal precautions, such as speaking in the plain language and utilizing the teach-back approach. This approach helps you to have your patient say back to you what you taught them in a manner where you get that peace of mind that you know that they understand and will correctly follow through with the described plan of action.
So let's get back to our case. So the 16-year-old patient is seen in the orthopedist's office. There's an effusion in the knee. There's somewhat limited range of motion with flexion. There's laxity with an anterior jaw and Lockman examination and a Sagan fracture on x-ray. There's obvious concern for an ACL tear, and an MRI is recommended to confirm the diagnosis. We encounter similar issues to what we discussed earlier. How the parents are Spanish speaking. Do we have an interpreter that can communicate in the language that they understand? What is their health literacy and their level of comprehension about what this means? Are we relying on the 16-year-old to be the translator, or are we using a formal medical translator to do this? An MRI means another doctor's office, another day out of work for the parents, another attempt to try to travel to another site to get the care that's needed. What's their insurance status once again? Is there a deductible with their plan? Are they going to have to pay some amount of this out of pocket to get that MRI? So we're able to get that MRI, and it does confirm an ACL tear. Luckily for this kid, the cartilage and the menisci are okay. It's an isolated ACL injury. So now what? If you ask around, every single orthopedic surgeon is going to say that that 16-year-old with an ACL tear needs surgery to address it. But there are many questions that come with this. Do we recommend prehab or early rehabilitation to get the swelling and motion down, or do we go with a recommendation for early surgery? We know there's a risk of stiffness with early surgery, but there's a risk of cartilage and meniscus damage if we wait too long. When do we do the surgery? What's the timing around school? Are crutches allowed at school and on the bus? Will this kid be able to go to school postoperatively, or will he have to miss a significant amount of time? If that's the case, we postpone the surgery to time it with winter or summer break to minimize the time out of school. Again, insurance status. Is there a copay, a deductible, a cost for that insurance, for that surgery? Communication with family. There's a lot of details that goes into surgery, not just when and how to do it, but the technique and the expected recovery. That full discussion of risks, benefits, and alternatives that needs to be communicated with the patient and the family. What's the post-op course going to be like? We're talking about a protracted recovery for approximately a year, and the parents need to understand this going in. All these details need to be laid out and understood in a language that they understand. So shared decision-making. We've decided that we're going to proceed with surgery and that question of timing. If the school doesn't allow crutches, do we want to wait? Or do we want to get this kid out of school and do homeschooling during a period of time of recovery? And is homeschool even allowed in that district? We know that delay from injury to surgery with an ACL tear can lead to further risk. We can see condylar damage as early as 8 weeks, meniscal damage as early as 5 months or sooner after surgery. And the parents need to understand that while it may be best for the family situation to wait until summer break for this surgery, that may not be in the best interest of their child and his knee. And this is a shared decision-making that must be done with the patient, his family, and again, in a language that they understand. It brings into issue, again, that discussion of health literacy. So they choose to have their surgery. It's an uneventful ACL reconstruction. The patient's discharged home that day with a brace and crutches, instructions for how to manage the bandage and pain medicine, instructions on starting physical therapy. Again, this is communication. It's communication with the patient and the family. And there's concerns here as well, as there's been with every step of this patient's healthcare. What is his living situation? With crutches, does he have stairs in his house? Is there access to transportation? Do they have a car? Can he get from place to place? Or is a freshly post-op patient can be using crutches and getting on the bus? Pain medication. The patient's likely going to have a short course of narcotic pain medication. He's a teenager. There's risks associated with that. Do the parents understand? Are they going to hold the pain medicine and dispense it to their child? Or is the patient himself going to be responsible for his pain medication at the age of 16? Comprehension of the postoperative instructions. Weight-bearing status, crutches, the importance of the brace. Physical therapy. Physical therapy is going to be necessary for a long period of time after surgery. Do they understand the importance? The risks of stiffness, flexion contracture, permanent damage if physical therapy is not done in a timely fashion. How is he going to get to physical therapy 2 to 3 times per week? Who's going to take him? Who's going to pay for it? Is there a copay with their insurance? Again, these issues present themselves every step of the way in terms of this athlete's care. We're able to get PT started as soon as possible. We're able to get his range of motion, gait training, all the things that are needed. And it doesn't just end there. Physical therapy after ACL reconstruction is protracted. We're going to look at 6 weeks to get motion, 3 months until we start jogging, 6 months until light activity, and 9 months till a year to get back to sports. We need to find a PT location that's in network. How close to their house is it? Based on insurance status, not every physical therapy location may be amenable to seeing this patient. So the further away they have to travel, the longer time that it takes to get there. And again, the need for car transportation. How quickly is that first appointment? How many sessions does that patient need and how many will that insurance cover? Is there a copay with that? And we're starting to add up, as you can see, costs for the family, not just in time, but in money of copay, deductible, insurance, MRIs, visits, as well as physical therapy here. It's starting to add up over time. How do we clear this athlete to get back on the field? Is it time-based? Are we using office-based testing? Are we using a formal return to play protocol? This requires, again, more PT visits. Are we able to even get this patient into PT for 6 months, 9 months, a year? At some point, do they have to be discharged because of the number of visits their insurance company allows and rely them to do a home exercise program? When that patient comes back to the office, can they even get cleared by doing a formal return to play? Are there benefits that will cover that? Are we going to use an ACL brace? Is that something that insurance will cover? And we focused a lot now on this athlete's knee, but what about everything else? What impact does this have, all of these PT visits, time out on crutches? What does it have on his schoolwork? Was he working to raise some money to help support the family? Has he been able to work during this time? What about his social interactions with his friends? What about his physical and mental health and everything else about that athlete and that patient? He spends a year focusing on his knee. What about the rest of it?
Yeah. So as we know, although quality of care is improving for all populations, the access to healthcare is deteriorating and the disparities are not changing. It said by 2060, it's estimated that 57% of the US population will be composed of these members that we consider these underrepresented groups that are affected by these social determinants of health. It's estimated that by eliminating these healthcare disparities would decrease medical expenditure by about $29.4 billion. We spoke before about the co-pays and insurance costs, and typically with PT visits without insurance, a patient can be looking at paying about $75 to $150 per visit. And with these rehabs, you're usually looking to go into PT probably about twice a week, every month. So when you think of that copay number, a patient could potentially be paying something that's looking like their rent, which they may not be able to afford. So how, as healthcare providers, are we able to address the social determinants of health in these changing social climates? We definitely need to learn more about the athlete's true social history. Make sure you're gaining all that information from the beginning, because there's so many more factors than just the injury on hand that may play a crucial part in the recovery process and the treatment that you're looking to give your patient or athlete. You want to make sure that you're being able to modify the treatment plan based on these social determinants that you identify in your history talking to the athlete. Provide that support and counseling for any health issues. With this athlete, football may have been his saving grace and his way to be maybe getting out of a circumstance that he may not have wanted to be a part of. You never know how he feels, so you want to be able to try to be there to talk. Provide education and support to your patient or athlete regarding their clinical management, ensuring that you're speaking in that language that they can understand and helping them recall back the same information that you gave them. Help them to address the social needs and provide referrals to physicians based on the gaps in their coverage that you note in their medical history.
So in this case, we have an ACL tear in a patient of a lower socioeconomic status. In looking through the literature, we know that a lower socioeconomic status with ACL tears is associated with a decreased or delayed access to care, approximately 50% longer time period to obtain an MRI, a greater than 1 month increase from injury to surgery compared to people with private insurance. There's an increase in time from surgery until starting physical therapy, and a fewer number of PT sessions covered by insurance. This has been shown with many other orthopedic conditions as well, including things like fracture care and shoulder instability. And there's actually a recent article published in the middle of October this year looking at these issues with shoulder instability in our adolescent athletes, which show a similar delayed access to care for underserved patients. And just remember, this ACL case is just one example. Social determinants of health impact every aspect of patient care. And it's something that they live with every single day of their lives in terms of obtaining the care that's needed and having high quality, good access to health care.
Thank you.